Today we are going to deal with the topic of vasoplegia treatment, the past, the present and the future. Let us see the definition of vasoplegia. Vasoplegia is the syndrome of pathological low systemic vascular resistance, a clinical feature of which is low blood pressure in the presence of normal raised cardiac output. This is how the mechanism of loss of vasomotor tone in resistance results leading to hypotension in vasoplegia. It is also known as vasodilatory shock, the etiologies of which are mainly septic, cardiogenic, neurogenic and anaphylactic shock. So the pathogenesis is pathogen associated molecular patterns in sepsis, whereas damage associated molecular patterns in polytrauma and burns. Whereas in drugs, anaphylaxis and neurogenic shock, there are some other mechanisms also. Now coming to the subject proper, vasoplegia treatment, the main class of drugs which we use are adrenergic vasopressors, of which dopamine, epinephrine, norepinephrine and phenylephrine are the main components of catecholamines. Now what are the current recommendations? Norepinephrine is the first line of management in vasodilator or vasoplegic shock. It increases the advantage of norepinephrine is it increases the mean arterial pressure without increasing the heart rate. And cardiac index is increased due to rising end diastolic stroke volume and it has a direct effect on cardiac myocytes. Now what are the advantages of noradrenaline over the other catecholamines? It is a very potent vasopressor. Lactate levels do not increase, so it guides in resuscitation. It increases cardiac index without increasing the heart rate and without increasing the oxygen consumption, and it preserves the ventricular arterial coupling mechanism. So what are the disadvantages of noradrenaline? If we use noradrenaline at higher doses, it leads to receptor desensitization and leads to the mechanism of tachyphylaxis. So when this tachyphylaxis occurs, we have to use the other vasoconstrictors which do not depend upon the receptors of catecholamines. So there comes the concept of decatecholaminization. Because of increased oxidative stress, because of interaction with cellular energy metabolism, because of modulation of inflammatory response, we have to go for decatecholaminization. So it means non-catecholamine vasopressors we have to use to reduce the desensitization. So what are the other vasopressors? The first one is vasopressin as a second line agent. The surviving sepsis guidelines say we have to use at 0.03 units per minute of vasopressin in order to raise the mean arterial pressure to a target of more than or equal to 65 mmHg or to decrease the norepinephrine dosage. So what are the main trials which are leading to vasopressin evidence? VAST study, where it reduces the lower 28-day mortality when compared with norepinephrine, and VANX trial, where post-operative in CABG patients post-operative vasoplegia has been reduced and also lesser incidences of atrial fibrillation when compared to norepinephrine. Now the last study is VANISH study, where it did not show any improvement in kidney failure free days. Now coming to epinephrine, it is the third line agent when 2018 surviving sepsis guidelines say it is used as a secondary or tertiary vasopressor. However, the main disadvantage of epinephrine is higher incidence of tachycardia, lactic acidosis and hyperglycemia. Unless there is myocardial dysfunction, we should not use epinephrine as an agent for septic shock. However, it is a medication of choice in case of anaphylactic shock. And coming to phenylephrine, it is not recommended in the management of septic shock. However, in vasoplegic shock, due to anesthetic-induced hypotension from induction agents and volatile anesthetics and relaxant medications, it is used. It can be administered peripherally. Dopamine, it is used in highly selective people where there is low risk of relative bradycardia. Bradycardia is present and low risk of developing tachyarrhythmias are present through D1 type receptors. Dopamine, it has to be strictly used with concomitant vasodilatory shock with cardiac dysfunction. So it maintains it should be used only with people who have adequate blood pressure reserve and low cardiac output. However, we have to keep in mind the development of cardiac ischemia and dysrhythmias. Now coming to future aspects of vasoplegia treatment, celepressin. Vasopressin acts on B1A, B1B and B2 receptors, leading to undesirable side effects like fluid accumulation, microvascular thrombosis and vasodilation. However, celepressin is selective B1A receptor agonist. It does not induce the Van Willebrand factor also. Now, one of the popular studies, he et al. He showed the celepressin as a first-time vasopressor. It improved the MAP, cardiac index, blood lactate levels and fluid balance and also higher survival rates. Coming to angiotensin 2, it acts through GP coupled receptors 81 and 82, and 82 the main effects include vasoconstriction, aldosterone secretion, vasopressin release and cardiac remodeling. The famous study is ATHOS 3 study. which improved the map within 3 hours of infusion of angiotensin 2. It improved the SOFA score, it reduced the serious adverse effects, and it reduced the death rates by day 28. Coming to methylene blue, it inhibits the excessive production and activity of both nitric oxide and cyclic GMP. It also can be used in cardiac bypass surgeries and septic shock, poisoning, post-liver transplant and anaphylactic patients. And the dose of methylene blue is 1 to 2 mg per kg over 15 minutes and followed by an infusion of 0.5 mg per kg over 6 hours. It also antagonizes the endothelial nitric oxide synthase activity. The potential dangers include hemolytic anemia and development of methemoglobinemia in G6PD deficiency patients. It also causes serotonin syndrome in case of people using serotonin reuptake inhibitors. Thiamine, it is a main cofactor in Krebs cycle, so it is in septic patients there is decrease in vitamin B1 level, so the mitochondrial dysfunction is present in septic patients. So whenever we support with thiamine, it improves the mitochondrial dysfunction. And similar to thiamine, we can add ascorbic acid. It is an essential factor for the synthesis of catecholamines. It the decreased levels of ascorbic acid up to 70% levels in septic shock patients supports the usage of ascorbic acid. The other advantages of ascorbic acid are vitamin C is it scavenges the free radicals, it downregulates the inflammatory mediators, and it enhances the vasopressor receptor sensitivity. What is Marek's protocol? Marek's used ascorbic acid at 1.5 gram every 6 hours for 4 days, hydrocortisone 50 mg 6 hourly for 7 days, and thiamine 200 mg every 12 hourly for 4 days. However, it is a low study using only 100 people. So, Victor's trial is ongoing, the results of which are awaited for the widespread use of Marek's protocol. Coming to the modulation of sympathetic system, how it helps in assisting of vasoplegic treatment. The main components used in modulation of sympathetic system are alpha-2 agonists, selective beta-1 blockade, glucocorticoids, vasopressin combinations, and adrenomedulin blocking. Coming to alpha-2 agonists, dexmedetomidine and clonidine are most common drugs. They restore the response to vasoconstrictors such as alpha-1 agonist and angiotensin 2. By reducing the central sympathetic activity. The main mechanism of action is lesser desensitization of peripheral adrenergic receptors, and also there is direct vasopressor effect on alpha-2 agonists. Now coming to selective beta-1 blockade, esmolol is the most common drug which we use for selective beta-1 blockade. It reduces the heart rate without apparent side effects in case of septic shock patients. It also improves the arterial elastance and restores the ventricular arterial coupling. Glucocorticoids, it improves the vascular responsiveness due to vasopressors through genomic and non-genomic inhibition. Low doses of glucocorticoids, it restores the vascular responsiveness to norepinephrine. The main study involving glucocorticoids is approach study where hydrocortisone 60 mg IV QID is used and fludrocortisone 50 microgram tablet is used. It has a beneficial effect of 90-day mortality and shock reversal. And coming to vasopressor combinations, norepinephrine with vasopressin or norepinephrine with angiotensin 2, the studies are VAST and ETHOS 3. Coming to adrenomedulin blocking, adrenomedulin is a double-edged sword. Adrenomedulin supplementation, it improves the endothelial function, it attenuates the systemic inflammation, it reverses the hypodynamic circulation and pulmonary hypertension. It also reduces the kidney dysfunction and organ injury. However, it also has a side effect like high levels of adrenomedulin are associated with short-term mortality and vasopressor requirement. Coming to studies, there is ongoing study with usage of adrisizumab. It is a monoclonal antibody against the N-terminal end of human adrenomedulin in patients with early septic shock. Coming to role of genomics and pharmacogenomics, there are many people which respond to different kinds of vasopressors in different ways. So Nakada et al. Demonstrated beta to adrenergic receptor gene polymorphism. However, it is seen only in 5 to 7% of the people. However, it shows the altered responsiveness to adrenergic agonist and mortality in septic shock. Conclusions. Vasoplegia is the most common feature. So the cornerstone of which is utilization of norepinephrine as the first line agent. However, the advanced potential treatments, they need to be considered in their capacity to decrease the to improve the survival and decrease the major morbidity and also the cost effectiveness benefit ratio. Thank you.